Welcome to the Lightmed webinar. I am Anna Sanseau. I am a professor in ophthalmology. I'm a PI of clinical trials. I did from some drops and some surgical device. I work in Buenos Aires, Argentina. I'm a glaucoma specialist. I'm a director of Consultorios Gonella. I published 8 scientific papers in Argentina and worldwide, last in clinical ophthalmology in November 2019. I received a few awards, one for a scientific video out at SAO in 1998, and also in Canada for a scientific poster. I presented many scientific posters and several free papers in Argentina and around the world. I'm also a co-author of Phacoemulsification in Challenging and Difficult Cases book in collaboration with Dr. Lu and Howard Fine. I did the leadership course from the Pan American Association. I'm also a board of our national magazine. I like to play tennis, swim, and travel. I would like to share with you my experience with the LIGHTLas A10. First of all, I want to talk about glaucoma. What is glaucoma? It is the second most common cause of blindness worldwide, a disease with complex etiologies, while its common characteristic is a chronic progressive optic neuropathy with elevated intraocular pressure. Damage in the retinal ganglion cells and visual field loss, it is very important. If it's not treated, blindness is the final outcome. Intraocular pressure depends on aqueous humor production and outflow. But what is important aqueous humor? Aqueous humor is produced here in the ciliary body, then goes through the pupil to the anterior chamber, through the trabecular meshwork, outside through the canal de Schelem and episcleral vessels. It is very important to identify these anatomical structures because it's the site where we are going to perform the surgical procedures. Here we have the ciliary body with the ciliary process, muscles, and pars plana, the trabecular meshwork, here the Schelem canal, and the collector vessels. We could classify glaucoma by different ways, according to etiology, in primary, secondary, or infantile, according to gonioscopy, in open angle or angle closure, that is very important, or according to the site of alteration of aqueous humor outflow. It is located in the anterior trabecular meshwork or inside the trabecular or post-trabecular. There are a few glaucoma solutions we could use. First of all, we think about the medical treatment, and it's related to the use of eye drops. Then we thought about laser procedures like peripheral iridotomy or trabeculoplasty or SP-Mode. Then we thought in surgical treatments like trabeculectomy, tubes, mix, NPDS, or cyclophotocoagulation. Lightmed has a few laser solutions for glaucoma. They have a JAG or an SLT that you can both together in the same machine, or you can have them separately. You have also a special laser in an SP-Mode for laser trabeculoplasty, and the TSCPC or SP-Mode, it is the LIGHTLas. This is the one we are going to focus on. I want to, first of all, separate the indications for the SLT and the SP-Mode, not to be confused. We use SLT as a first line of treatment, as we read in the LIGHT study, or associated to the first line therapy with a prostaglandin, to treat ocular hypertensive patients or treat mild glaucoma. Instead, SP-Mode, we are going to use it to treat mild to severe glaucoma, refractory glaucoma, or any patients who need glaucoma surgery, and it's not a candidate for trabeculectomy or a tube. As you can see, it covers a broad spectrum. It is very important to know this surgical site, the ciliary body, because it's the place we are going to perform all these procedures. The ciliary body is located here in this area at 3 millimeters away from limbus, and is called the surgical limbus. Here we could see the iris and of course the ciliary body formed by the pars pliccata. The pars pliccata is the anterior part of it. It has 70 to 100 ciliary process. It is the portion responsible for producing aqueous humor. Then we have 3 ciliary muscles. They play an important role in trabecular meshwork, dynamics, and outflow of aqueous humor through the eye, and the pars plana that is attached to the uvea located near the junction of the iris and sclera. To see the ciliary epithelium here, it is formed by 2 layers of cells surrounded by basal membrane. One of these cells is highly pigmented. It is very important because in these cells, it is produced the aqueous humors by ultrafiltration, simple diffusion. The ciliary body could be studied by the UVM. UVM is the ultrasound biomicroscope, which presents images of deep structures with high energy sonic waves, as we could see here in this upper image. We can see all the structures of the eye alive and exact location of this ciliary body. The ciliary process, we could see this anatomical view, histological view, with the ciliary process and the ciliary muscles and the relation of the ciliary muscles with the scleral spur and the trabecular meshwork. We could also perform gonioscopy, an eye exam using a gonio lens that could be done in the slit lamp or in an operating microscope to see the anterior chamber. It is good to see all the angular structures and classify the type of glaucoma. It helps us to understand physiopathology of glaucoma. Here we could see in this image the ciliary process through a surgical iridectomy, and this is the way they look in real life. But cyclo extraction has been done for many years with a high rate of complication. It was used to decrease intraocular pressure by modified production of aqueous humor by ciliary body. It was reserved for refractory glaucoma in eyes with best correct visual acuity less than 20/200. Because of the high side effects like inflammation or the risk of ptosis bulbi because of overtreatment, it makes us to choose only in a few cases. It is an infrared diode with an H10 nanometers wavelength. It has great absorption in melanin-containing tissue and acts directly over the ciliary body. The goal is to decrease the intraocular pressure, increasing outflow of aqueous humor and decreases the aqueous humor production. But the thermal effect of the laser has been demonstrated to induce coagulative necrosis of the pars pliccata. This is a problem. Necrosis of surrounding tissue is a collateral damage. The TSCPC, the necrosis created by thermal damage, the burn mark, is only an unwanted side effect of photocoagulation. Based on this limitation, they designed what is called the SP-Mode, which is the difference in a continuous mode and a SP-Mode. In a continuous wave, we are going to have this. For example, for a power of 2000 milliwatts, when we apply the probe over the tissue and press the foot pedal, we are going to deliver all the potency all the time we have the foot pedal pressed and the probe over the tissue. So we are going to have a lot of energy in this tissue with energy delivered through the surrounding tissue, creating thermal damage of this area. SP-Mode instead makes work different. For example, for a 2000 milliwatts of power and a cycle and a pulse of, for example, 1600 microseconds, we are going to have the 2000 milliwatts applied over the tissue just between 500 or 600 microseconds. And this is called the on time. the rest of the time of this pulse, the laser is going to be in an off mode. That means that even if we have the pressing the foot pedal, there is not energy delivered to the eye through this time, the off time. And that is called the duty cycle. What is the duty cycle? It's a relation between an on time over on plus off time. For example, for a duty cycle of 30%, we said that the on time could be 500 microseconds over 1,600 microseconds. The difference between the 30 to 31.3 is just very, very small and has no clinical significance, because for a 31.3 is 500 on time over 1,600, and for a 30% is 480 microseconds over 1,600 total time of pulse. So between 500 and 480, there is very, very small time difference between 30% and 31.3% of duty cycle. And this situation, the SP mode, this relation between on and off time, makes the energy not concentrate in this tissue, and we don't get the thermal damage and the necrosis of these surrounding tissues when we apply the laser. The SP mode, this microsecond laser technology, is the function with total pulse duration with 1,600 microseconds with an on time with 500 microseconds and 1,100 microseconds of pulse interval. This is the off time. So we could work with data cycles of 31.3 or 30%, and there's not much difference between them. The single pulse duration and intervals are still adjustable from the remote control. The therapeutic effect of the SP mode is caused from biological activity generated around the target spot. The off period restricts accumulation of caloric energy, preventing burning and collateral damage. There are three proposed mechanisms of action for the SP mode. First is the cyclomodulation. It's the biological activity over the pigmented cells here at the ciliary process. They produce histochemical changes inside without necrosis. The second one is the contraction of the longitudinal fibers of the ciliary muscles that cause traction of scleral spur, and with this contraction, opening the trabecular meshwork and Schlemm canal, allowing aqueous humor flow more easily through the Schlemm canal. And the third one, modify the cell junction between ciliary, body, choroides, and sclera to increase the outflow through the uveoscleral space. How can I perform the SP mode and the TSCPC? In the SP mode, I perform 2 cycles with 80 or 90 seconds per hemisphere in a continuum arc motion without taking off the probe out of the eye, just sliding in an arc motion at 3 millimeters away from limbus. That is very important. I skip 3 and 9 position. I use a power between 2,000 to 2,500 milliwatts, and the duty cycle is 31.3 or 30%. For the TSCPC, I apply 5 to 7 laser applications per quadrant, maximum 3 quadrants. It's very important to keep one free quadrant just to allow ciliary process still working. Minimizing pop sound. It is very important not to listen a pop every time you press the foot pedal, because that means that you are delivering too much energy inside the eye and you will have a lot of complications. This laser operates in a continuous wave mode. I apply the probe each time and no more than 5 to 7, remember, per quadrant. The power is 2,000 milliwatts in a total duration of 2 seconds. The main indications for the SP mode is refractory glaucoma, not a candidate for traditional glaucoma surgery like trabeculectomy or tubes. Any patient that needs surgery, but we can't do anything else for it, as a first option sometimes because it is less aggressive. For the TSCPC, we still have the same indication like refractory glaucoma and neovascular. The LIGHTLas HN clinical application, I like to perform a topical and neuroleptic analgesic. The anesthetic is an inferior parabulban with the neurolepto and topical proparacaine drops. I put the blephorostat to keep the eyes open and identify the 3 mm from limbus, and I mark with a blue pen like we use in refractive surgery in 3, 9, 6, and 12 hours, just to make sure when I make the arc, I do it following these signals and be sure I am working on the 3 mm distance. I use lidocaine gel over the eye to make the probe move easily over the eye. I start the procedure and I could select the probe it is more comfortable to use, and it depends on the type of eye I'm working on. There are some eyes that are too small and they have so little spot to work that I need a very, very small probe, or maybe sometimes I could use the bigger one. I use a caliper to mark, forceps to move the eye. I wash with Richer after the procedure. I apply dexamethasone intravenous with analgesic also intravenous to make patients feel more comfortable after the procedure. I stop the prostaglandins, but continue with the timolol dorzolamide. I choose the parameters for the SP-Mode, the power 2000 to 2500 milliwatts, timer 80 to 96, maximum for each procedure, that is cycle 31.3% or 30. And then for the TSCPC, the power is just 2000 milliwatts, duration 2 seconds in a continuous way. I'm going to share with you this video. You could see here how this looks the machine, the foot pedal, the probes. I mark the 3 mm. It is very important. I made my own marks at 3 mm in each part of the eye. It is easy to understand the exact position of the ciliary body. Here you have to identify the 3 and 9 hours. You don't have to touch these hours. Then I turn on the machine before I connect the probe. Then I press the power button. Here in the screen, you're going to have all the information you need. You first go to this button. Here in this button, you want to choose the type of program you want to perform. A cyclophotocoagulation or a subcycle is the SP-Mode. So we choose the SP-Mode. I like to say it loudly so everyone listen what I'm touching to be sure I'm in the right program, but you could read it here to check if you are okay. Here you have the power. Here you have in the SP-Mode the data cycle you can change. The aiming beam, just keep it in 5. This is the foot pedal. I press it. It is wireless and small, very easy to use and comfortable. You can also change parameters with this foot pedal. Here is the way you see the screen with the duration. This is the place you want to set each cycle you want to play to each hemisphere. For example, 80 or 90 seconds here, and this is the total time, and this is the timer that's going to count when you start the treatment to know how much time you apply the laser in each hemisphere. Here you could move up and down each parameter. Then you press the standby button and you're ready to treat the patient. Here you are following the time. This is the clock. The position, it is very important to be comfortable. You put the probe just very perpendicular to the eye over the 3 millimeters. You have to be sure not to let the probe get down, just to keep it perpendicular and make the movement in an arc motion. This is the way looks how we perform the SP mode. We apply the probe, we have the change in the ciliary process, and outside we couldn't see anything. It's okay. It is working even if we don't see anything. But in the TSCPC, we put the probe in the same position. We want to see sometimes pigment dispersion, and we are going to listen sometimes the pops. Remember not to listen too much pops because it means the high delivery energy on the eye. I'm going to share with you some clinical cases. Like this girl, a female, 22 years old, she had Rubella syndrome. She had glaucoma secondary to pseudophakia. She underwent that surgery when she was 2 years old. In right eye, she had 1 glaucoma surgery, and in her left eye, 6 glaucoma surgery. 2 were Ahmed tubes, and she had now chronic corneal edema because she has an intensive eye rubbing, as you could see here in this image. This is the way she treats her eyes because of the rubbing. Her visual acuity is bad, especially in the left eye, but her only good eye, with a -4, she reached 20/100. And in that eye, she has 40 millimeters with maximum therapy, with this visual field. This is the left visual field. So in a girl like this, which would be the best surgical option? Would you perform a trabeculectomy or a tube in a 22 years girl with a Rubella syndrome, with too many surgery, with the experience we had in the left eye? We choose for a SP mode in August 2019 because we thought it was less aggressive for a girl who rubs her eyes a lot. After the SP mode, nowadays in June 2020, we get a better visual acuity, 20/70 with her -4, and the eye pressure is 12 millimeters with brinzolamide twice a day. And this is the way her right eye looks now. Look here, the eye, this is the place we pass the probe. This is the way the eye looks. The patient is happy, comfortable, and kept her vision, and give us the opportunity in a young girl to perform future procedures if we need them when she gets older. In this case, this female, 76-year-old, she had pseudofoliative glaucoma and pseudophakia. She had multifocal intraocular lens in both eyes, but she developed an MALT in the left eye, and she's treated with chemotherapy. Her visual acuity is still very good, 20/20/20/25, and the intraocular pressure is controlled quite good in the right eye with timolol dorzolamide and latanoprost, but the left eye has 35 millimeters with maximum therapy. She has a mild lymphoma on her conjunctiva, only ocular lymphoma. And after many months treated with topical drops, we couldn't reach a good IOP in that eye. So we start to see how the visual fields start progressing the damage on the optic nerve. So what is next? Would you perform a surgical procedure that involves conjunctival in this patient? I don't want to touch this conjunctiva. So we decide to perform a SP mode treatment with very good results in August 2019. She gets a rapid recovery that led her to continue with her chemotherapy. She kept her visual acuity, and nowadays she has in her left IOP eye 12 millimeters of mercury, still with timolol dorzolamide. Remember, she has pseudofoliative glaucoma also, as you could see here in the pupil. In conclusion, the SP-Mode allows us to correct the eye pressure without touching the conjunctiva in this special case, allowing her to finish her chemotherapy and not to pass through a bad post-operative situation. This is the way the visual fields actually at July 2020 see the damage she had on her left eye. And now we are thinking to treat the right eye because it's still on maximum therapy. And we saw a very good response on the left eye. So maybe it would be a good option to perform the laser, the SP-Mode on the right eye now. This female, 71 years old, look at this photo. I want to show this. This is her maximum opening of the eyes. She cannot open her lids more than 5 millimeters. She had severe glaucoma, and we treat her with drops and SLT. She also has arrhythmia. We can't use beta blockers here. The severe ptosis with good best correct visual acuity and pressures with this primary open glaucoma around 21 and 18 millimeters with treatment. And we have progression on the visual field of both eyes. As you could see here in the right eye, from 2018 to 2020, we see how this visual field gets worse. Even in the left eye, we have the same situation. A really severe damage appeared on the visual field. We find quite difficult to perform a trabeculectomy or a tube in a patient that we can't open her eyes because of this enophthalmia and limited supraduction she has, and with a maximum 5 millimeters opening. So the solution we found for this woman was to perform SP-Mode bilateral with a month's difference between both eyes in February of this year. Nowadays, we have a pressure of 12 and 13 millimeters still with drops, but with a better IOP results related to the severe damage she needs, an IOP target very, very low. This pupil change we see here, it was because I make a laser application. The probe moved near the iris, so I touch the iris and I get this dyschorhea here. That's the reason I use forceps to move the eye to make sure I am at the 3 millimeters. And the last case, this female, 76 years old, diagnosed with pseudofoliative glaucoma, as you could see here in this image, with best correct visual acuity in the right eye, 20/30, and very bad visual acuity on the left. The IOP in the left is 40 millimeters, and she was treated only with latanoprost. What we found on the left eye was a central venous thrombosis. So this is a very complex patient because we need to treat the retina and the glaucoma. So which procedure do you think is the best option for the left eye? She needs a glaucoma surgery, of course, but if we perform the glaucoma surgery, we cannot treat her with laser anti-beige at the same time. So we need to choose a treatment that allows us to treat both the retina and the glaucoma at the same time. That's the reason we choose to perform the TSCPC in 2 quadrants on the left eye and finish the treatment with the anti-beige and the retinal laser to keep the eye and prevent the neovascular glaucoma. We get an IOP of 15 millimeters of mercury is still treated with timolol dorzolamide in that eye. And on the right eye, we thought it was not good, the pressure, the 18 millimeters, so we add an SLT to the latanoprost, getting an IOP drop and 12 millimeters of mercury, and we are planning to perform a phacoemulsification in that eye to get better her vision. What we find with the SP-Mode and the TSCPC is that they are very easy procedures with less complications if you follow the instructions. The learning curve is very short, and it is possible to repeat it. The patients are happy because they had a fast post-operative recovery with a comfortable one, with less amount post-operative visit, and nowadays this is very important considering this pandemic time. The TSCPC with the LIGHTLas 810 is still a good option to treat severe cases of glaucoma. The SP-Mode is the latest evolution of diode laser. It's a safe procedure with a wide range of indications, good patient compliance, repeatable, and it's an opportunity also to combine the SP-Mode and the TSCPC in selected cases. Thank you very much for your attention, and we are opening for questions.
Thank you very much, Dr. Sanseau. That was a very great presentation. We've got a lot of very positive feedback for the information that you shared with us today. For now, we will just wait until somebody asks a question. So far, we do not have any questions, but we will wait and see if anybody has any. Please feel free to type it in the question section of the control panel. Thank you.
Thank you. Maybe I would and others some comments.
Yes, if you'd like to add some comments, no problem. Yeah.
There are not much publications that combines the SP-Mode with the TSCPC, but there is an option that they are working a lot, and many doctors are choosing to combine both procedures in especially difficult cases. So when you try to reach in PubMed or the places looking for research, they are not much really talking about that, but it is very good, and it's work because if you remember the mechanism of action you have for the SP-Mode, it's nice to think that it's not just to work on the ciliary process. You work in all the ways that works on the aqueous humor production and outflow. That's very, very important.
Okay, Dr. Sanseau, we have some questions, so I will read them out loud. We have got one from a doctor in Guatemala. He's asking, can SLT and transcleral be combined?
Yes, you could combine the traditional SLT combined with the because they work in different places. I mean, the SLT works when you apply the laser over the trabecular meshwork by a gonio lens. You make these cells change their biological activity, and when you put the probe over the ciliary process, you get the biological activity in the ciliary process cells, and the others mechanism of action are more mechanical, not biological activity over the trabecular measure. So you combine the action of the mechanical work of the longitudinal ciliary muscle with the action of the SLT over the trabecular cell, and this is a biological activity. You could perform both without a problem. What I think is the target patient who performs an SLT is quite different for the patient you choose for an SP-Mode. I think the SP-Mode is for a patient you have with glaucoma treatment, you need, and the drops are not enough. You are thinking about surgery here. And for SLT, you are thinking about adding a drop or starting a treatment. This is nowadays the way we position both lasers. I hope it is clear. It is very important. The light study I mentioned before. The light study was a study performed in the United Kingdom that talked about the cost of performing SLT to patients who start treatment for glaucoma with patients with start with drops to treat their glaucoma. And they say that they have the same efficacy in treat patients with SLT or starting with drops, and it was cheaper in the cases they treated with SLT than the one in the cases we treated with drops. And with SLT, you are not adding anything over the eye, so the eye is protected. You are protecting the conjunctiva and the cornea, so you are going to be healthy for the future. So that's the reason we position the SLT as a first-line treatment, or in competition with a prostaglandin, or combine it with a prostaglandin.
Perfect. Thank you so much. So you did mention with SP, TSCPC, you can repeat the treatment. How much time do you usually wait to repeat the treatment?
To repeat a treatment, I had to see what happened the first 6 months after I perform it. I did a treatment, for example, today. I see the reaction of the eye and how the pressure drops in the next 6 months. If it works, I mean, if I have a good answer, a nice eye intraocular pressure drop, I could repeat it after 6 or 8 months, not before of that, because what we know is that changes inside the eye are happening almost a year after I perform these procedures. So I could expect answers in IOP pressure even after 6 months. But if I perform the treatment today, but I did not see any answer in the IOP pressure, I'm not going to repeat it. That is important to know. I need to be sure that I have an eye intraocular pressure drop, and how much IOP pressure I need, at least 20% of the basal IOP pressure this patient has. For example, I have the patient with 45 millimeters of mercury with maximal therapy, and I get it after the treatment. I get 25 millimeters of mercury with just 1 drop. Of course, it's a very good answer for the treatment, but it's still not the IOP pressure I need for the patient. So in this case, I could repeat it because I get a good answer, but not reach the IOP target I need for the patient. But if I treat it with 45 millimeters and I get 40 millimeters in 1 month, 2 months before the treatment, I'm not going to do it again. But what I could do, if I did SP-Mode and I did not get a good answer, I could do a TSCPC, because SP-Mode is not necrosis. TSCPC, I had necrosis. So I need to remember there are different ways of applying this laser. That's the reason I could combine both procedures, because they have different mechanisms of action. When I apply TSCPC in one quadrant, I'm killing the ciliary process. Entonces, I'm afraid to use the TSCPC sometimes a lot is because of the risk of ptosis bulbi, especially in only one eyes that are very, very bad, or the patient has only one eye. So I like to combine only one quadrant with TSCPC and apply in the rest of the eye the SP-Mode. And we have another situation, because many eyes we receive, they have failed 2 traps, 2 valves, so we don't have much space in the eye to apply laser. We know that it is better not to apply the probe over previous surgical sites, because you have the risk of problems with the sclera in that place. So if you're going to perform a case when you have 2 failed traps, 1 valve that doesn't work, it is good in that situation, or even it has oil in the eye, silicone oil, because he has a retinal surgery or whatever, I like to perform inferior 1 quadrant TSCPC, SP-Mode in the rest of the quadrants, and check in the next 4 to 6 months how it reacts. If I have a good answer in IOP pressure, but it's still not target, I want to repeat it. And I find good results in these difficult patients with silicone oil, because they have 3, 4 retina surgeries, and we don't have much to do in that eye many times, most of the time.
Okay, thank you. So what are the cases that we cannot use SP-Mode?
The cases for not to use SP-Mode are the one who has uveitis. Eyes with high risk of inflammation are not candidates to perform SP-Mode, because one of the mechanisms of action of this change in biological activity is creating inflammation in the eye. I treat this eye after, in my protocol, I leave the patient for 1 week with a prednisolone, a topical prednisolone, 3 or 4 times a day to handle the inflammation. But if you have an eye with high risk of inflammation, do not perform SP-Mode, because you're going to have a severe inflammation and even more complications. This is the main case. You don't have to do a SP-Mode. In the others, they are not neovascular glaucoma. In neovascular glaucoma, we know, because of the experience, that SP-Mode alone doesn't work to control IOP pressure. We need to perform a combined TSCPC with SP-Mode. We learn after doing a lot of cases of neovascular that it is better for that cases to perform the combined procedures. But it's not because the SP-Mode damaged the neovascular glaucoma, it's just because it doesn't make enough IOP drop in the eye. And the others, no, for keratoplasty is good. We did some patients who need glaucoma IOP control after a keratoplasty, and we have very, very good answer to the treatment. The pediatrics glaucomas are, it depends on the type of pediatric glaucoma they have. And in these cases, you have to perform by general anesthesia. I mean, you can do it by local. And it depends if it's a traditional, a classical pediatric glaucoma, or it is secondary to like pseudophakia or traumatic or related to a special syndrome. And in that case, maybe you have different type of answers. There is not a unique answer in the pediatric group.
Thank you very much. You did mention before that it is okay to perform SLT treatment and TSCPC treatment. How much time do you wait in between these treatments?
To combine both treatments, you mean?
Yes, if we follow SLT treatment and then TSCPC, how much time do you wait in between?
Oh, I could, 1 month, it's okay.
Okay. How much time do you wait until you establish failure of treatment?
For SLT, after a month. For SP-Mode, 6 months. Oh, if I get some IOP drop, I wait 6 months. If I didn't get IOP drop in the first 15, 20 days, I think it's a failure.
I see. Is this treatment suitable on a cataract patient?
Yes, you could do it.
Okay. In case you have a patient with higher IOP above 30 millimeter of mercury, will we need to increase the duration above 90 seconds?
Yes, you could do an increase to 90 seconds, or sometimes there is something that is not well established yet, that is this. When you pass in a SP mode in an arc motion, there are a few protocols. Someone said that you could pass the arc motion like this. If you have the 80 second, 20 seconds go, 20 back, 20 go, 20 back. Some people said, no, you need to go through slowly. Another said you need to go faster. What we learn is if you go slowly, you get better result than if you go faster when you're moving in the arc motion. So it is very important. Sometimes not the, I mean, time is important, but it's also important this if you go through this 80 seconds very, very slowly, more than if you add 10 seconds more. Sometimes you pass and you think, oh, I did it so fast. You just put another cycle, and maybe from this cycle you perform, instead of 80, you did 40 seconds for a new cycle over this area, because you feel you pass so fast in that hemisphere. So I prefer to do it just in three times in each hemisphere, like 30, 30, 30. I find good results doing like this, or 30, 30, 20. And if I can't use an hemisphere because I have so many other eye surgeries in that hemisphere, I make 2 treatments over the same hemisphere at the same moment. I mean, I apply the 80 seconds slowly, wait, and another 80 seconds slowly, because I cannot touch the other one, so I make higher. But the way we could increase the effect of the laser is increasing power, changing the duty cycle, and increasing the pulse duration. I think touching the pulse duration is not a good idea, because you lose control of how much energy are you applying over the eye. I think it's good to increase power, as to be sure you have in this on time you are using, that you know exactly how much is this on time. That should be between 500 to 600, no more than that time, and no more than 2,500 milliwatts. This is a range that is good, and you want to be safe using this duration and this time and power. If you apply more power, maybe you get more inflammation in the eye. If you change the cycle over 31.3, you're going to get also more inflammation. And if you use less than 30% of duty cycle, you're not going to get enough effect of the laser. But yes, moving power, moving duty cycle, and pulse duration are the main tools to increase or change the effectiveness of the laser.
Thank you very much. What is the risk of ptosis bulbi after performing TSCPC in a patient with neovascular glaucoma?
Oh, in medicine, you know, we don't have like in math exact numbers, but I consider that the risk of ptosis bulbi is always present. So I like to be more conservative. when I treat a neovascular glaucoma, and I did the TSCPC in 2 quadrants and do an SP mode in the rest of the quadrants and see how the eye reacts. If I get a nice response, a nice IOP drop, I know I have the opportunity to perform. I have another quadrant to treat by TSCPC if I need it. But touching 2 quadrants, I'm quite sure I'm not going to get the ptosis bulbi. The problem we have is that we don't know how much the ciliary process works and if there are ciliary process that work more than others. So we consider that the temporal area is the area that has the most working ciliary process. That's the reason we try not to touch these ones, allowing to keep aqueous humor production even around 20 millimeters. I mean, I prefer a patient with 23 millimeters of mercury and adding eye drops and be sure he's not going to have a ptosis bulbi, because I could go to another procedure, but if I if I cross the barrier, I cannot go back again. So I'm going to lose that eye. I mean, really, I lose some eyes in the last 20 years, and it's not a nice situation, really. Doing the traditional cyclodestructions procedure, and we did that in the 90s. We performed a lot of cyclodestruction procedures, and we get really a lot of ptosis bulbis for these patients. That's the reason it's a situation I don't like to be on. So be more conservative and think doing 2 procedures. I tell the patients, listen, your glaucoma is a hard one. It's secondary to your problem of retina or whatever the reason he has the neovascular. So we need to start treatment, and maybe you're going to need 2 or 3 treatments to be okay. So I let them know that it's not one solution, and we're going to see how it works the first time, maybe between 6 months after that treatment or a year after, I perform a second one if he needs it. And of course, it depends the visual acuity the patient has. If he's just to handle pain, I don't care if he keep pressures below 30 millimeters, it's okay. An eye with 20 to 30 millimeters of mercury, an eye without vision, I mean a blind eye, that we are doing the procedure just to help him to handle pain or having less pressure, to be more comfortable with the eye drops, it's okay. So it's going to work. But if you have this eye with maybe vision, some vision, and the patient needs that vision, be more conservative.
Okay. How long does it typically take the IOP to drop after TSCPC, and about which percentage would you expect this IOP to drop based on your experience?
You want to find a very, very high drop, 24 hours, you perform the procedure, because what we call the ciliary shock. So don't measure your results 24 hours after, because I think 99% of the patients are great. I mean, they get drops for 70% of the basal IOP they have. I mean, it's amazing, it's incredible. But when they recover for this ciliary shock and they start to work the real treatment we did, you find that in 3 weeks or 4 weeks after we did the treatment. But this is not the final outcome. The final outcome, I could tell the patient, is 3 months after we perform the treatment. So I performed the treatment today. I phoned the patient the day after. I did not make him come into the practice office, and I see him again 1 week after, 2 weeks after, and the 4 week. It's very, very comfortable. And then I say, okay, now you have less inflammation, the IOP drop is okay. That's the reason I do not move the IOP drops after 1 month of treatment. But I take away the prostaglandin because we know prostaglandins could increase inflammation in these eyes. And the patient is happy when you take away the oral acetazolamide and you just take away another drop, and he's using just 1 drop twice a day. He feels more relief, more comfortable.
After you perform SP mode, how do you know the treated areas? Because they're not visible.
We learn doing the UVM, and sometimes we take the UVM to the operating room to check the exact location of the ciliary body and ciliary process before start treatment. In some cases, we go with the patient bring us the UVM, and we ask to the operator, to the UVM, to mark us how millimeters away he find the ciliary process in each patient. There is another technique to find the exact location, and it's called transillumination, but it's not so easy to perform. I mean, you have to practice a lot to get real this hard line or dark line, as it is described, to see. I could see in some patients, and I tried to do it in others, and I couldn't find it really. I couldn't find the exact transillumination in each patient. We learn maybe when we start doing cyclophotocoagulation procedures in the 90s with the endoprobes, we mark in the eye with a blue pen outside, and then we push the eye to see through the pupil the location of the ciliary process, and then we, with the endoprobe, we just coagulate it, but through the eye. So we check that they are 3 millimeters, but this is the way we learn how it works, and anatomy was an experience we did many years before. So we know that nowadays is UVM or transillumination, the best options you have to check the exact position of the ciliary body and ciliary process.
Perfect, thank you. How long does the effect of the laser last?
The SP mode, you mean?
Yes.
Well, I started working with the SP mode in 4 years ago, but with the LIGHTLas that arrives in Argentina, we have just 1 year. Exactly in August last year, last year. So my experience is just, my own experience is just 4 years. But related to the articles I read, they have been working with the SP mode for the last, I think, 6 to 7 years. There are some published papers and related information, but the problem that there is not a good work that show you what happened with patients, for example, pseudophakic glaucoma with pseudophakic patients with glaucoma treated with maximum therapy without other pathology, and they perform SP mode or trabeculectomy. You don't have this type of protocols. They have all refractory glaucoma mixed together. That includes traumatic, neovascular, and that makes the results are with big differences, because one patient is going to work very well, the one that hasn't got much inflammation or really a real refractory glaucoma, and other eyes, they're not going to work. They're going to need the TSCPC directly because of the quality of the glaucoma. So what I think is My patients are good now. It is in 4 years or in 1 year, I have them very well controlled. But I know that neovasculars doesn't work well. They are the patient I need to retreat and to add the TSCPC. So we learn by experience in this situation. Or the pediatrics one. Doing pediatrics, we learn that not the pediatrics work all the same. But I like the way it works with the traditional glaucoma. I mean, patients with glaucoma, many medications, no other pathology associated. In these cases, with good visual acuity, in these patients, we have very good result as the patient I show you with the lymphoma of the conjunctiva. In this woman, more than 1 year with good results. I don't know how many years, because when we think about glaucoma treatment, we want something that lasts at least 20 years. I mean, that's the ideal treatment, but a trabeculectomy, a valve, a mix, 6 years, 5 years, 10 years, the reports are very, very different, and they are not a unique answer for each treatment. So what I think is we try to perform in patients the less aggressive treatment with the best result we could offer. And what I found in the SP mode is this option. It's very easy to perform, the patient is comfort, I could repeat it, I could do other procedure if I need it. So I don't, with SP mode, I have the trap, the valve, the tubes, the mix, I have everything to do if I want after that. So it's a good to start for me with an SP mode in these patients with maximum therapy, glaucomas, risks because they are losing visual field. So, but it is very important to respect the protocol you are doing, because if you just press and move the power and start playing without knowing exactly, you put the eye on risk, because you change the amount of energy you are applying to the eye, and of course, the type of answer you want to get. So, or you have, like you see, in the case I show you, the eye with the dyschordia. I mean, this patient, I move the probe next to the limbus, and I get this alteration of the pupil. And I have one patient with a midriatic situation, a chronic midriatic. She's still in a mild midriatic because I did it in the wrong position, of course. So we have to be sure the technique, the parameters, to talk with the patient. Every procedure we perform in a patient has risk. But of course, there is no endophthalmitis here, so it's very good. The patient goes to work the day after. The patient could do gym, play tennis, go to play football 2 days after the procedure. I mean, it's more comfortable.
Perfect, thank you. So when is the proper time to do transscleral? What pressure range do you recommend?
I think it's more than the pressure, is related to the target pressure the patient needs. Mm-hmm. If I have a patient with over 25 millimeters of mercury and maximum therapy, that patient needs surgery. And starting with SP mode is a good option. Maybe, like I showed the other treatment, the other patient who cannot open her eyes, she needs a surgery because she has 21 millimeters, but she had progression. So it is not the pressure, it is the pressure that the patient needs to stop the damage on her optic nerve. And that's what I think is the best option. Not the level of the pressure, it is the target pressure of the patient that what will make us decide the procedure we need. Because I know I could make drops of 30, 40, even 50% of from basal IOP. And it's like a traditional surgery, more than what an eye drop could offer.
Right.
So
okay, that's great. Thank you. Do you avoid doing laser over the bleb or tube of a previous trabeculectomy?
yes, I don't like to touch this area with the laser because I don't have any problem, but I heard some colleagues who really have to deal with something with perforation. It was not my case. I read it and I talked with colleagues, but I don't like to be through this situation. That's the reason when you receive this patient with 2 failed traps, 1 failed tube, for example, everything in the upper hemisphere, you have to do everything in the lower. And in the lower hemisphere, you can't do a trabeculectomy. It's not a good option. And you could put a valve there, of course, but I prefer to start with SP-Mode and TSCPC in that cases, and repeat them if I see good answers.
Thank you. Is the goal with transscleral the same as SLT to reduce glaucoma drops?
The TSCPC, I like to reserve for the hard cases, the patients who really we don't have anything else to do because of the risk of the disease. I mean, I talk with the patients. I say, listen, I can't do a trabeculectomy. I can't put another tube in your eye. I can't even treat you with any other procedure. The only thing I could do in your eye is this. It has risk, yes, but it's the only thing we could try. And I did it in a conservative way, as I told you before, because I treat in 1 or 2 quadrants, check what has happened, and if I need it, I try another quadrant if I have it. If not, maybe I retreat that area, keeping the same power. It depends on the first answer I get in that patient.
I see. Okay, thank you. How long does it take for both SP, TSCPC, and TSCPC to have a hypotensive effect?
The hypotensive effect you want to have in 24 hours, as we said before, like for the ciliary shock, but the real effect 3 weeks or 4 weeks after the procedure, we could say, yes, it's working.
Okay, great. Yeah. Did you experience any loss of near vision or high myopic patient post-operation, this procedure of SP mode? If yes, what is the solution in your opinion?
The patients that lose 1 or 2 lines were patients that had really, really severe retinal damage and severe glaucoma. There's no solution. When they lose that, they lose it. But in the patients I perform the laser, the SP mode, and they have good visual acuity, and it's just glaucoma. The only thing they have is just a glaucoma without a retinal damage. So I do not lose any lines of visual acuity. What I see that patients report the first aid, there are some modifications in the way they look the light. sometimes, especially the patients who had very bad vision because of their previous pathology. They say that they see more green, more yellow. They talk about colors. They talk about different shape of things for a few days. I think when you perform these procedures, we are touching, as we see in the mechanism of actions, we are touching all the accommodation system of the eye. So it's reasonable to have changes in the focus, in the vision, in the focus. Maybe in some, maybe you could find change in the glasses the patient has to wear. They do not lose vision. They change the prescription glasses. Maybe if they were using +2, for example, they change for a +1.75 or 2.5. Just because of the accommodation, the modifications in the accommodation, all the accommodation complex of the eye. And it's reasonable because we are touching all the ciliary muscles. We are touching all the place where the sonula and the lens is attached. The mydriasis, maybe it is still related to one of these changes sometimes we have. Of course, there is a mydriasis that is related when you perform too anterior the laser. But if you were on the ciliary body, you were very well located, you could have these changes. I separate changes, visual changes related to the use of glasses. I don't think they lose vision here. They just change prescription from changes in people who really lose 1 or 2 lines. And this group, the one who lose 1 or 2 lines, were patients with very complex retina and glaucoma situations. So I am not sure if they lose the vision because of the laser or just because they were losing it because of the severity of the pathology they had before. I mean, a patient who has retinal detachment, three retinal surgery, 2 glaucoma surgeries, silicone oil in the eye, pseudophakia. I mean, maybe he could lose 1 or 2 letters, but if we could, what I say to the patient is, we need to drop your eye pressure, because if I keep you with this high pressure, you are going to lose all the vision you have, not just 1 or 2 lines, all the vision. So we need to play with the risk benefit with this equation, just to know what we are putting in this balance. But there's no solution.
Thank you. So with a patient who has closed angle glaucoma induced by phakic IOL, would you use SP-Mode?
You said angle closure glaucoma and aphakic?
Yes, induced by a phakic IOL.
Well, in this patient, I could perform the SP-Mode, but I had to take away I mean, since a phakic IOL, it means that he has his own lens. So I need to take away to open the angle. But I perform the SP-Mode in this type of patient. I have nothing to lose. If it doesn't work, I could do another thing. And a trabeculectomy in this patient is more risky than an SP-Mode, because in an SP-Mode, I don't work with an eye open. The eye is closed. So the risk of hypertensive problems during the surgery, they're better to handle that if I have a trabeculectomy and I have my eye open and the patient may have a severe hypertension during the surgery, I could lose the eye in that situation. So SP-Mode is going to be a very, very good option in these cases.
good. Thank you so much.
Of course, take away the lens, of course, no, and treat the cause of the.
Okay, great. Thank you. So you mentioned that, some cases maybe it won't, maybe this procedure will fail. I mean, within your experience, typically, what is your failure rate?
Well, my failure rate is related to the neovascular cases. These are the one, and I did maybe 10. I have already 50, 55 patients treated. So maybe 10 were my failure, but I think, as I told you before, we need to split, separate the cases. We cannot mix the critical ones, the silicone oil, three surgical failure, with the patient who he's on drops and we are thinking to perform something on that eye. This group is going to work very well. This group, it depends. If I mix the results, maybe when I have a high rate of failure than if I separate both. In this group, maybe you have a success rate of between 80%, 90%, because there are patients who want to work. In the other, maybe 50, 60, 70, depends the group you are handling.
Okay, thank you. This next question, I'm not quite sure if my pronunciation is correct, so I will try. What about Pterygium patients and mature, yes, and mature vascular-related Pterygium?
Luckily, the Pterygium usually is located over 3 and 9 hours. And these are the places we do not have to touch with the laser. So we could perform SP-Mode or TSCPC in the other space of the eye without touching 3 and 6. So if I have a surgical procedure for Pterygium in that eye, it doesn't interfere with my treatment. So you could combine both, not at the same time, of course, but you have a patient could have a Pterygium surgery and you could perform an SP-Mode, and they are not going to fight between each procedures.
Okay. How long do you keep the patient with corticoids after the procedure? And do you add any mydriatic?
No, I do not add diuretics. I just keep them 1 week. 1 week between 4 to 3 times per day. But remember that after the surgery, intravenous, I add dexamethasone. So the patient left the operating room with analgesic and dexamethasone by his intravenous line, and topical, we use prednisolone, acetato, prednisolone drops 3 or 4 times per day. It depends on the type of eye I have. If it's a quiet eye, I leave it 3 times per day. When I phone him the day after and I ask, hey, hello, how do you feel? Don't worry, the eye is going to be red, maybe it's going to itch a bit, and do you have some pain? If the patient is okay, I keep it. If the patient says, well, yes, I feel quite discomfort, like a bit pain over my eye, something like that, maybe I could add 1 more drop of the prednisolone. Not diuretics, not oral diuretics, and maybe I could add some artificial tears to protect the conjunctiva and the cornea. No more than that.
Okay, thank you. for now, Dr. Sanseau, we've answered all of the questions in the question box. Oh, I'm sorry. There's one more that just came through. What is the rate of complications such as neurotrophic keratopathy and LSCD with both SP-Mode TSCPC and TSCPC?
The neurotrophic keratopathy, and the second you said?
It says LSCD. I'm not sure what it stands for.
LSCD. I'm not sure exactly what these letters means, but what I say that I understand the question, because what we think about, we are touching the superficial conjunctiva, and the limbus contains the most vital cells to protect our eye, the cornea and the conjunctiva. But the laser really doesn't affect the conjunctiva. When you apply the laser, it goes directly to the pigmented cells of the ciliary process. This laser has not action on the conjunctiva. So maybe the damage you could have is a traumatic one when you pass the probe, not because of the action of the laser. So I recommend to add viscoelastic, or like I use lidocaine gel over the conjunctiva to make the probe move easily over it. Because what I found is some keratitis after the procedure, but this keratitis, I found it more related to the use of the lidocaine gel, not because of the laser. In the patients, I use viscoelastic, like hyaluronate or whatever viscoelastic you have in the operating room. The patients feel more comfortable because it's like an artificial tear, a heavy artificial tear. But the lidocaine gel is quite aggressive to the ocular surface. So we need to wash it with physiol or hair after the procedure to be sure there's not more lidocaine gel over the surface of the eye. And these patients were the ones who have the keratitis in my cases. I do not have superficial lesion, superficial damage in this patient, and I didn't read reports telling that.
Okay, perfect. Thank you. So I did get the response, the LSCD as a lumbar stem cell deficiency.
Yes, I saw something like that. That's I told you about the limbal and these stem cells.
Yes.
Yes. I mean, what I would consider in that case is if the patient has a nevus, a pigmented nevus in the limbus, I would not apply the laser over that nevus because of the high pigmented limbus area. Maybe you will get some absorption of the laser in that pigmented cells over the conjunctiva. But we don't need to expect limbus deficiency related to the laser application. We could expect some aggressive over the conjunctiva because of the probe. So we have to be quite, be gentle in the way we press the eye and move the probe.
Okay, perfect. Thank you. We have about 3 minutes left for any questions because there's, let me see. There's a couple more that just came through. I'm sorry. Do you make any changes to highly pigmented conjunctiva?
I tried not to pass over this highly pigmented. Luckily, we don't have here patients with this highly pigmented conjunctiva. Our patients are Hispanic, most Caucasic Hispanic, with the normal conjunctival for us. So I don't have to pass through a special situation. just a small nevus one time, and that's it.
Mm-hmm. Okay. We have a couple minutes left as well, so we can wait for any more questions, or if you would like to make any last comments, Dr. Sanseau. We have 2 minutes left, so please feel free.
I would like to say that most of the things we read about SP-Mode, I mean, with these procedures, with the new development of laser, are based on experience and case reported. And as I tell you before, the first idea was to treat patients as with refractory glaucoma, but because of the the low rate of complication of the SP-Mode with high rate of results, and the way that this procedure is done and the comfort to the patient and all the situation, they are making more common the use of the SP-Mode to treat glaucomas who need surgery as a first line surgery instead of starting with a trabeculectomy. So it is important to be careful, to sit with the patient, to study carefully, maybe to ask for a UVM to check the ciliary process. I mean, to be sure where we are going to do the procedure, how, the condition of the patient, the visual acuity, the iris, talking about the complications, I mean, changes in the pupil, maybe changes in, sometimes in the sclera, small changes, but I think no more than that, I expect, for the SP-Mode.
Okay, perfect. Thank you so much. I will just take this time to close the meeting, and lots of very great compliments, Dr. Sanseau. Thank you very much. The information is very helpful. And for those that missed the presentation or need to review some of the material, we did record the presentation and we are going to share it. And if you have any other questions for Dr. Sanseau, you can email clinicalmd@lightmed.com and I will discuss it with Dr. Sanseau. At any point in time, you can send these emails with any questions. For now, we are out of time. And thank you again for joining us today. And thank you again, Dr. Sanseau, for the great presentation.
Thank you. Thank you to you.